We're going to be talking about the new adult health toolkit from the OIF. Dr. Krakow is going to be talking to us on hormone therapies. Erin Carter is going to be talking to us about navigating the initial OI diagnosis. Ricky Carroll from New Moors is going to talk to us about optimizing neonatal care for infants with OI. And then Nancy Harry will be talking about maximizing school accommodations and an education plan. So we have a lot for everyone, and hopefully you will be able to put your questions in the chat, and so we can get those questions to the speakers and answer those for you. So next slide, Erica.
Tracy, I'm just going to if I could take over and just take a couple minutes to go over some of our programs before we dive into the agenda tonight.
Great.
All right. I just have a couple programs I want to highlight for the group tonight. The first is our national conference, which is coming up July 19th through 21st in Omaha, Nebraska. This is our first national conference in person since the pandemic. We know our community is so excited to be back in person, so we're hoping you're saving the date for that, and please share this information with your families. Registration is up, it's online, it's open. Ken is going to put the link to that page in the chat right now. Also on that web page, you'll see the program for the event. We're thrilled to be back in Omaha. Thank you to Dr. Paula Esposito, who I see on the call, and the team over at Omaha for being our host clinic. Please take a look at that program. We want to make sure, you'll see on the right side of this slide here, the financial assistance. We want to make sure that financial barriers are not a reason that families aren't attending. We have these 3 programs that will cover the costs for registration and travel and lodging. Historically, the foundation has funded anybody who's applied. So we're covering, a third of the attendees to be there. So please make sure that your families know about that resource. It's a very easy application. All of those are, and OIF staff is happy to help families fill that out. On that same note, we're able to do that because we have some incredible sponsors for this event, and there are sponsorship opportunities available to clinics. They start at $1,500, and we'll make sure that you have that information in the email that you'll get immediately following this program. But it's really a great way to make sure that you're in the room for those 3.5 days, and you can share information about your clinic and your services with all of the attendees that are there for the conference. We usually get anywhere from 500, 600, 700 attendees at these conferences. So we hope you'll take advantage of that as well. Last thing I want to mention is our Jeannie Coleman Impact Grant program. This is an incredible program that I'm always surprised that a lot of our docs and a lot of our families don't know about. The application's open 1 time a year. It's coming up in January, and it covers items and services that insurances usually don't. So wheelchairs, hearing aids, college tuition, laptops. We've done a lot of accessible ramps in homes. So a lot of services that we know our families can't find other funding for. So please make sure you're sharing this information with your families as well. Ken is going to put that link in the chat, and if you have any questions about this program or any of them, please reach out to me. I'll make sure that my email is also in the chat. The last thing I'm going to do, I'm going to throw this over to, well, Dr. Tosi, I don't know who's on the call yet, but our ECHO program that I think most of you know about, we'll put it in the chat as well, but the Rare Bone Disease ECHO is the first Thursday of every month. And then our OI ECHO is starting again in December. You'll see the upcoming sessions for both of those programs here on the screen. All of the recordings for every ECHO are also housed on our website. So we hope you'll take advantage of that. And now, Tracy, I'm going to pass it right back over to you just to say a few words about our current clinical trials that we're working with.
Sure. Just wanted to make sure that you knew about a few current studies that are going on right now. At the OI Foundation, we work hard to get information out to the community about these various studies, so they can, decide if they want to participate in a clinical trial. So Ultragenics right now has 2 studies going on, the Orbit study and the Cosmic study. Sanofi has a phase 1 trial going on right now. there is an OI well-being study that we are doing in conjunction with Baylor College of Medicine and the Brittle Bone Disorders Consortium, a very interesting study, and that's where we're going to be asking people to participate through a survey and through like one-on-one focus group kind of situation. And then we're still recruiting people for the use of clear aligners for the treatment of dental issues. And that's part of the brittle bone disorders disorder consortium as well. If you want any information on any of these studies, you can go to our website. We have the information, we have the contact information, especially for the ultragenics studies. They are recruiting right now. So there's information on our website, their website, and at clinicaltrials.gov as well. So just wanted to make you aware of those things going on.
Excellent. So those are the announcements we have, and we're gonna jump right into the agenda for tonight. First up, I'm very excited to introduce Tracy Mulroy, who's going to be talking about the Foundation's newest resource. It's the Adult Health Toolkit. It's been a real labor of love for this past year. We've worked with our medical advisors and our community, and Tracy Mulroy, who is actually our newest adult initiative community chair. So Tracy's really taking the lead on being our liaison between the foundation and our community with all of the adult health initiatives that the foundation has been working on for this past month. So Tracy, over to you.
Thank you so much, Erica. I'm so honored to be here. My name is Tracy. I am an adult living with type 3 OI. I was previously a member of the OIF Board of Directors. I am the founder and chair of the Jamie Kendall Fund for OI Adult Health. And as Erica just said, the newly formed Community Adult Health Initiatives. So that's a lot of words. But I think you can tell from the various titles I have that my passion is really OI adult health. And before I dive in, I just really want to give a heartfelt thank you and shout out to the OI Foundation and Dr. Tosi for their amazing commitment and leadership in this area. When Jamie Kendall died and I went to the foundation and said, we need to do more, and they were just in from day one, and they, with Dr. Tosi, have really changed the landscape of OI adult health. And I think there's just more and more exciting things to come. So I just really want to say thank you to them. So as part of all of these exciting adult health initiatives that we have going on, as Erica mentioned, we're really proud to announce the brand new, hot off the press, OI Adult Health Toolkit, information for adults living with OI, their families, and medical professionals. Just for some housekeeping and logistical things, the toolkit will be emailed to everybody on this call tonight after the meeting. It will also be posted on the OIF website and emailed out to the OIF community. You may also email the foundation for a printed copy if you would like, and it will be available in Spanish at the beginning of 2024. So, and as Erica said, this has been a real labor of love, and it shows. It's incredible. It provides up-to-date and medically verified information for adults. It's groundbreaking. There's nothing like it. And not only does it include much needed information, but it also has really cool interactive pages that allow an adult with OI to, for example, track their medication or their surgeries or fractures, basic health history. So I'm going to show you more of those pages tonight. But it's really amazing. And the reason this toolkit is so critical is that OI adults really face a dearth of expertise about the complexities of OI. There's so many gaps in care, and we really have to be our own advocates. And this toolkit gives us the knowledge and the power to be able to do that effectively. You know, you can go into your doctor and say, here, Dr. Smith, this is the latest and greatest from the OI Foundation. And, you know, here's how OI might affect my heart. And this is what I need. There's just been nothing like it. And it's so needed. Just to give a couple quick examples, personal stories of facing these, you know, lack of expertise. I had a very serious fall at the beginning of 2022, and I broke at least seven bones, major bones, tibia, femur, acetabulum, pelvis, a lot of bones. And I was taken to my local hospital, which is affiliated with Johns Hopkins, is across the street from NIH. I mean, I am not in a medical desert. I live in Bethesda, Maryland. I am in an area of, you know, incredible medical expertise, and yet it is still incredibly difficult to access good care. So they did, from the outset, it was clear they didn't understand the complexities of OI. And this was my bones. This is something that I have taken for granted, that most doctors at least understand about breaking bones, but no, they didn't understand how to give me proper and adequate pain control. They didn't understand that some of my fractures might not even have shown up on X-ray. So while 7 did show up, there were potentially more that didn't. And really significantly, they did not understand that I ambulate differently. And all of the therapies were set up for, you know, able-bodied people. So, you know, I had a broken hand and all these fractures in my leg, and I couldn't move. I mean, I literally couldn't transfer. And they really were at a total loss of how to deal with it. And so what they did was discharge me. So anyway, it was pretty harrowing experience. And as I said, that was my bone. So imagine a more complicated issue like cardiac care. So I had my first heart attack about 20 years ago in my 30s. And I had no family history of heart disease or heart attacks. And I was in my 30s, right? So they said, oh, it's indigestion, we're gonna send you home. And I mean, thank goodness that I am a good advocate, because I said, this is not indigestion. Something is going on with my heart and I'm not leaving. And I finally got a cardiologist to listen to me. And it turned out that I had a 90% blockage in my LAD, or the Widowmaker, as they call it. So if I had left as they wanted me to, I wouldn't be sitting here right now giving this talk. So there's a lot of, you know, really great things, but these kinds of things sometimes are life and death. So this information is just so critical to get out to the community. And if I had had a resource like this, as I sat in that emergency room trying to convince them that it was my heart, I mean, it would have changed the entire experience. So that's what this toolkit can do. All right, let's dive in and take a little look. And I'm going to try to share my screen. I am not the most proficient, but we'll see. Okay. Can you guys see it?
Yep, looks great. We see it.
Okay. All right. So this is the cover page. This is what you'll all get tonight. And just gonna sort of highlight a few things. We'll just take a quick stop here at the table of contents to give you just a brief overview. So in the beginning, it talks about navigating adult OI care. And it also talks about transitioning from pediatric to adult care. So while there is good care in a lot of places for kids with OI, it sort of falls off a cliff once they reach adulthood. That's something that Dr. Tosi has really been working on. It also then talks about establishing a multidisciplinary team and what disciplines you may need on your team because you have OI. And then, as you can see here, take charge of your health. And this just goes into some areas, sort of what I was just touching on, of things that have a particular impact on OI adults. And some of these things are, sort of newer discoveries: cardiac care, pulmonary care, right? We're learning a lot more about those things, and there's a lot of recent information that I think is just not getting out. And also gastrointestinal care is an issue that's sort of bubbling up as something that's a lot of adults with OI are experiencing. So, and you can read the other things here, but it's about being your own advocate in each of these areas. All right, I'm going to jump down now to some of the interactive parts because they're so cool. Okay, so I was supposed to do that live. Okay, so here's your a page for your multidisciplinary care team, and it lists, each kind of provider that somebody with OI may come into contact with. And it, as I said, it's interactive. So, I can type in right now, Dr. Tosi, and it's there, and, all of her contact information. I mean, this is something that should be on every single adult with OI's refrigerator. It's an incredible tracking device. And then more towards the end, you guys can read all of this. So, okay, so here's some more interactive tools. So this is a basic health history tracker. Again, it's interactive. So at the top where it says type or mutation, I can type in type 3. And it, can help you keep track of bone density, echocardiograms, pulmonary function, all of the, issues that adults with OI are dealing with. And it's all in one place. It's wonderful. And then we have the orthopedic history tracker. So, instead of having to, write out everything, you can just literally click, like, I broke my right femur and this was the date. So again, really just incredibly helpful. I haven't ever had anything like this. In my 50s. I mean, when I fill out forms, I just have to write numerous fractures. Something like this would have really been a huge benefit, and will be a huge benefit. Next up is the medication tracker. Sorry that you have to look at this sideways with me. But it's, again, interactive: name of medication, the doctor, the purpose, any reactions or side effects. There's a couple pages of that. And then finally, surgical history tracker. Same thing, it helps you keep track in one place of all of the surgeries you've had, who did them, any notes, so that you can take all of this information to your doctor, to your multidisciplinary team, and have accurate, up-to-date information. So thank you so much for your time and for listening. We ask that you, read this through. I've learned a lot from reading it. I'm not a doctor, but, maybe everybody learns. And it is the latest and greatest information. So thank you in advance for reading it. We also really ask you to share this with your patients who are adults living with OI. And your colleagues. We need to get the information out as many ways as possible, and we need your help to do that. So thank you so much for your time. I'll be around for the discussion if there are any questions. Thanks so much for listening.
Thank you, Tracy. Thank you. And as Tracy said, we're going to email a copy of this to everyone who's on the call tonight. It's also available for download on our website, and printed copies are available to you in your clinics. You just reach out to us at phonelink@oaf.org and let us know how many copies you'd like. We'll send them off to you in the mail. And right in the beginning of the new year, we'll have it available in Spanish as well. And I see Dr. Tosi has joined us. Hi, Dr. Tosi, can you hear us?
I can. Now, the real question is, can you hear me? I have bad internet connection.
We can hear you.
Is that a yes?
Yes, loud and clear.
Can you hear me?
Yes.
Oh, wonderful. I
just-
want to first apologize to everybody that I'm running late, but I have been trying to get on the internet. I'm in deepest, darkest Massachusetts today. I don't know what's going on with internet here, but it's grand to have you, and thank you so much for attending today. I don't want to let us fall behind schedule. We'll make some announcements sort of midstream today, but right now I want to turn this over.
And we lost her. So,
I think she was going to say, though, she'd like to turn this over to Dr. Krakow, who's here to talk to us about hormone therapies for men and women. Dr. Krakow.
So that was great. The toolkit is incredibly important and so well done. And thank you for inviting me, Laura, and to all my friends who I can see out there. I'm thrilled to see you and wish we were all in person. I am going to share my screen. And I'm going to talk about hormone therapies for women and men with osteogenesis imperfecta. This is a 3D rendering of a hormone for all of us. We know that it is a protein that is made in one organ, can be made locally, but also can be made in one place and then travel to other locations to have an effect. So I sort of want to start a little bit with life expectancy, because I think that the important part is that if you look back at life expectancy in, the early 1900s, it was not very long, and people didn't have to really worry about hormones because they really didn't live long enough to deal with their loss of their home hormones. And I need to do one thing, just minimize. So after the 1918 flu epidemic and World War II and HIV, or just epidemics in general, life expectancy has gradually trended upward. And that's great news for both sexes. For men, it's not been quite as impressive as for females, but it has gone up. One of the things that, I do think we have to recognize in the last 3 years, because of COVID, drug overdoses, followed by heart disease, chronic liver disease, and suicide, we've lost 26 years worth of progress. So I think for all of us on the line, we have to sort of take this seriously and figure out what to do in addition to taking care of our patients with OI who are at risk for COVID, drug overdoses, heart disease, chronic liver disease, and suicide. I'm going to sort of start with women. And I think for many of you, you've seen this sort of cartoon that I've made that for me, women's health is not just menopause. It's across the entire lifespan of a woman. And in each one of these categories, there are different issues that women face. They have unique health issues that include pregnancy, menopause, and the female genital tract. There are health issues that can affect both men and women similarly and differently. And I think Tracy did a really important job talking about the effect of heart attacks on women. Women are more likely to die after a heart attack than men, even though men are more likely to have heart attacks. Women are more likely to show signs of depression and anxiety than men. The effects of sexually transmitted diseases can be much more serious in women. Osteoarthritis affects more women than men, and women are more likely to have urinary tract problems. Alcohol usage, I think, is a really important thing to talk about with our patients, because alcohol not only has serious effects in both men and women, it has serious effects on bone. It increases the risk of osteoporosis and decreases bone density. And while people have touted the positive effects of small amounts of alcohol on cardiovascular health, it does, we don't know what the effects of moderate use are, and we don't know what the effect of moderate use on bone, and it's very unclear. And clearly large amounts of alcohol increase your risk of both breast cancer and heart disease. But, I want to talk a little bit about menopause, because I think the issue of hormones and menopause are really important. Menopausal symptoms can have a substantial effect on quality of life in both women and men, but more on women. I mean, they do affect performance in the workplace. There are metabolic issues with menopause. There's cardiovascular, there's musculoskeletal changes, there's urogenital and skin changes, there's sexual dysfunction, and clearly there's an effect on osteoporosis. So I had to throw this in because I think this is really sort of tongue in cheek, but we're all aging. So we're all all the women on the line are gonna go through menopause, and that with aging comes wisdom. I'm very interested, I'm kind of obsessed by elephants, but elephants actually rely on women, their elder women or their elder females, to be the matriarchs of their very complex social network. And they carry a trove of crucial information critical to the well-being and success of the family. They really are the bedrock of these tribes. And interestingly, I think that this is something that we don't talk often about with our female patients, and with our female patients with OI, that often, they carry the burdens of their parents as well as their children. Elephants live until they're 70 years old, and it's really these female elephants that lead the group because they avoid the unnecessary trails. They're more adept at recognizing predator dangers than male elephants are. They remember when and where the resources are available, and they tend to keep a cooler head than the male elephants. And of course, they have very large brains, likely contributing to their excellent memory. But menopause also comes with your hormones going out of balance. And I think, one of the things that's been interesting for me as an OBGYN is that OBGYNs and gynecologists see menopause very differently than internists do. And even the recommendations of treating menopause and bone health are very different between gynecologists and internists. And we can have a discussion about this later. What is menopause? Really, menopause occurs in women younger than 60 years of age. And the issue of treating menopause is really based on treating people before 10 years. I think the more difficult thing for us in the OI community is that you start to lose bone mass before your menses actually completely stop. And how to get to these women is really, really important. Usually, gynecologists and internists will call menopause when you're no longer having any menses and you're having hot flashes and night sweats. But the issue is that you've already lost a substantial amount of bone mass when that happens. Clearly, if you're symptomatic, you're likely to benefit from hormone therapy. For women with early menopause, so people who have menopause before the age of 50, hormone therapy is recommended. Observational studies suggest that the risk of thromboembolism and stroke is lower with transdermal, which is skin, patches with estrogen, than with oral hormone therapy. Compounded bioidentical hormone therapies have not been approved by the FDA. They're not recommended because we can't actually officially tell you how much medication is in them. The data from the Prevention Society suggests that hormones are not recommended for primary or secondary prevention of coronary artery disease or dementia. And there's a lot of debate in the community about them. There are non-hormonal therapies that have been shown to reduce hot flashes, and they include serotonin reuptake inhibitors, gabapentins, weight loss, cognitive behavioral therapy. But these non-hormonal therapies have no positive effect on bone. And for women with only general urinary symptoms, local vaginal therapies are recommended. But I guess my take-home message is that all of these things are recommended for people who don't have OI. They're just women who are going through menopause. And I am not sure that these recommendations actually are 100% correct in OI. So clearly, sex hormones have an effect on bone. And so this is a cartoon, and I think all of you know this, but estrogen has a positive effect on osteoblast activity. It can have a really important effect on inhibiting osteoclast behavior by inhibiting NFAT and rank ligand activity. And one of the things that happens is with the loss of estrogen, you uncouple bone and you increase your osteoclast activity at the expense of osteoblast activity. And this is in women without OI. Androgens, for example, testosterone, also have a positive effect on bone. They increase osteoblast activity, they increase osteocyte activity, and they inhibit osteoclast. So both estrogens and testosterones have a positive effect on bone. And there's a cartoon to the right of all the effects of hormones on bone. They're involved in closing your growth plate, but they also regulate osteoclast and osteoblast generation and affect apoptosis. So it's really critical that we recognize the effect of these hormones on bone. In menopause, there's a significant bone loss. And as I noted, and this is really my take-home message, it happens before your last period ends. But the Women's Health Initiative, which was really what gave estrogen a bad name, did show that they decreased hip fractures by approximately 33%. And this is in women without OI. And so I really do think that there may be a role for prolonged estrogen hormonal treatment for selective women with OI. And it's really, I've been using very standard recommendations of low dose oral therapy with estradiol or the transdermal patch. If someone's had a hysterectomy, they don't need to use any progesterone at all. And it's really progesterone now that is thought to increase the risk of breast cancer with combined hormonal therapy. So for women without a uterus, I think the risk of breast cancer and hormonal therapy is very low. I mean, breast cancer and just with single dose estrogen therapy. But I do want to talk a little bit about men's health, and I will not say that I am a urologist or that this is my expertise, but I think that we've overlooked the importance of male health. And there are long-standing patterns in the literature that indicate that men are challenged to effectively manage their health and or illness. If you look at the adult male population between the ages of 18 and 65, which account for about 35% of our population, the general health of men is worse than that of women. Women attend doctor's visits and preventative services at approximately 100% higher rate than men. There's been many articles written about the social construct that tries to explain connections between masculine behaviors and health behaviors. And it's really thought that men's avoidance of health promotion and professional health care services may result from the masculine ideals of self-reliance, stoicism, and competitiveness. Essentially, there can't be anything wrong with me. I can take care of myself. I really do think as a society, we need to improve men's health literacy. And admittedly, the concept of men's health is relatively new and an evolving specialty. There are things that men do that I think negatively impact their health as well as their bone health. They're non-help seeking as a group. There's an increased use of tobacco. There's an increased use of alcohol. They may have some poor eating habits relative to women, physical inactivity, and steroid use, which may not be a huge issue in the OI community, but in general, men's health, the use of steroids is actually not uncommon, and it's thought to be, people use them to increase their muscle mass, for achievement, status, and winning, and they both can negatively impact their health as well as their bone health. Testosterone is an anabolic steroid which regulates carbohydrates, lipids, protein metabolism, and energy. Testosterone deficiency is associated with reduced lean body mass, reduced bone mineral density, increased adiposity, reduced energy and sexual function. It's associated with adverse changes when it's low in your lipid profiles and can increase pro-inflammatory factors. Increased pro-inflammatory factors can increase the risk of arteriosclerosis, coronary artery disease, and adverse cardiovascular events. And the controversy remains, but I think the literature does support that normalization of testosterone deficiency is associated with a reduced risk of myocardial infarctions and mortality. The literature is all over the place, but I think overall, when you read it, there is a balance towards the benefit of having aging men have normal levels of testosterone. But of course, the controversies continue. The most recent literature that I could find did show that normalizing testosterone did have beneficial effects on bone mineral density, again, in the non-OI community, but sexual function, body fat, body mass, and anemia, and that there were the potential effects on venous thrombosis and coronary artery plaques was really not there. There was no effects on cognitive function, fatigue, and hemoglobin A1C. So overall, I think that the benefits of having normal levels of testosterone outweigh the risk. I think when people start on treatment, the most common side effects that I read about were that there was breathing disturbances during sleep, some breast swelling and tenderness, ankle swelling, and acne that resolved. I, as a gynecologist, do not believe that there is any benefit to giving women testosterone, though out in the community, people have talked about, treating women with testosterone, and I don't think the data supports it. So with that, I am done, and I'm open to any questions, or if you want to hold the questions till the end.
Thank you. It was a great talk. Before we jump into questions, I'm going to see if we can connect with Dr. Tosi again. I see us called in. Dr. Tosi, can you hear us?
So I do think we have time for some questions, Erica. Yes, or are we waiting till the
Yeah,
end?
absolutely. We can.
Okay. If anyone has a question, they can unmute themselves and. Or you can type them in the chat and we'll ask them for you.
So I guess my take-home message to all of us who are providers is that as Tracy was talking about, as people age, we should pay attention to menopause. I think that in the OI community, for women who don't have a contraindication to hormone treatment, that they should be counseled extensively on considering hormone treatments as their menses become irregular to actually stabilize the bone that they have. And that for our adult providers, I think it's important to pay attention to testosterone levels, which is something that I don't think we really think about, but it's not, I think it's important to sort of ask about sexual function and to get testosterone levels in men as they age.
Erica, I'm not sure if we have that as one of the tests or whatever in the adult toolkit. Do we? Measuring testosterone?
We do not, but we can put that in a revision, absolutely.
Yeah, we should run it by the group, but you know, again, I'm not an expert on, but all my readings really did support the role of adequate testosterone levels, not going supra, but again, like menopause, it goes down, and it's something that we should be paying attention to, especially as people live older. My colleagues who are out there, I'd be welcome to hear what their opinions are.
Mhm.
Can you hear me now?
Yes.
Am I echoing? I fear I am. But I think that is a really, really important issue. We have paid such significant attention to women's bone health. And we're really not yet pushing for evaluation of strategies for men's bone health. And I really thank you for bringing that to the fore, so to speak, because as we look at where the foundation needs to focus, we have really, not me, Tracy has really responded to the requests of the community to really look at the issues of pain. But this is an area across the board where we've got tremendous unanswered questions. Thank you.
Thank you very much. I'm going to turn it over to Erin Carter. Erin's joining us from the Hospital for Special Surgery to talk about the initial OI diagnosis and family genetic counseling. Erin?
Hi, everyone. I am excited to be here tonight. Let me share my screen. Looks good?
Great.
Okay, thank you. I might stop my video while I talk, just in the interest of internet bandwidth. I'm presenting here from home, but obviously I'm here and I can flip back on when I'm done talking. Thank you to Dr. Tosi and everyone at the OI Foundation for the invitation to speak with you all tonight. For those of you who don't know me, my name is Erin Carter, and I'm the clinic coordinator at Hospital for Special Surgery's multidisciplinary Catherine O. and Alan C. Greenberg Center for Skeletal Dysplasias here in New York City. I am trained as a genetic counselor and have been asked to talk with you all tonight about navigating the initial OI diagnosis with an emphasis on family counseling. My goal is for you all to leave this talk understanding what genetic counseling is and to think about what the initial OI diagnosis means to both you as different provider types and how it might be different for the individual patients and families who present to your various clinics for care. I'm going to include information that I think everyone needs access to about the genetics of OI, natural history, and help us to think about building a health team for proactive care of your patients with a team of collaborators and consultants, as well as some basic resources to provide and to provide a framework for how you might approach psychosocial support of families and patients through the initial diagnosis and beyond. Okay. There we go. So what is genetic counseling? It's really a communication process which deals with the occurrence or risk of recurrence of a genetic disorder in a patient or family. Genetic counselors play an essential role as members of the multidisciplinary health team in guiding and supporting patients who seek more information about how inherited conditions might affect them and or their families, and to help order and interpret genetic testing based on both personal and family health history. The genetic counseling process seeks to empower clients and patients with this type of genetic information to improve overall healthcare, while also providing emotional support for patients and families as they navigate the healthcare system and make decisions regarding care. Goals of the genetic counseling process vary. They may include providing information about testing options, assessing psychological well-being, helping patients and families communicate about genetic risk, facilitating adaptation to grief and loss, interpreting test results, assisting with decision-making and referrals to specialists and support groups, providing written resources, offering peer-to-peer connections, and any combination of these things. Genetic counselors such as myself and some of my colleagues on this call are master's level professionals with advanced training in both medical genetics and counseling, though many patients also receive information about genetic conditions in the context of primary care or specialty care from health practitioners who are not trained geneticists. This includes many of you on this call as well. It might come from a family history questionnaire, an interview with a physician in the orthopedic clinic where they're treating a fracture, or a so-called simple blood test, such as an alkaline phosphatase level in the metabolic bone clinic. So what is osteogenesis imperfecta? The clinical findings, radiographic features, and genetics of OI are well described in the literature, and I imagine especially well understood by the audience here tonight. But OI is a group of heritable connective tissue disorders. Though clinical manifestations of OI vary by type, all forms include brittle bones. There can be short stature, blue sclera, cardiopulmonary problems, dental problems, hearing loss may also be present. It's important to remember that OI is also genetically heterogeneous. Roughly 90% of people with OI have dominant variants in one of the genes encoding type 1 collagen, either making a decreased amount of type 1 collagen in the case of type 1 OI, or a different quality collagen in the cases of types 2, 3, and 4 OI. Additionally, over the past couple of decades, mostly recessive acting variants have been discovered in a long list of genes that encode proteins which interact with type 1 collagen in the body. In 2023, my team regards the OI group as a type 1 collagenopathy and counsels patients and families as such. With advances in genetic testing, the question of OI may be first raised in the absence of any signs or symptoms. And people of all sexes and genders can have OI and all different ancestry groups. Features of OI may be first apparent from early in pregnancies to onset later in life, reflecting the extent of bone deformity and fracture predisposition at different stages of development or postnatal age. And depending on the age of presentation, OI can be difficult to distinguish from some other genetic and non-genetic causes of fractures, including non-accidental injury or abuse. So diagnosis of OI and other genetic skeletal dysplasias is really based on review of clinical findings, radiographic findings, and molecular genetic test results. Sometimes I picture it as 3 legs of a stool upon which we all sit. This leads us to ponder, what is the initial OI diagnosis? Given the clinical and genetic heterogeneity, and depending on a person's practice specialty, this story can be harder to pin down than you might think at first. Scenario A, a 21-year-old is referred by their PCP to an ear, nose, and throat specialist for evaluation and treatment of hearing loss. The specialist notices bluish-gray sclera and tells the patient that hearing loss is a common feature in OI, which they assume the patient has. Scenario B, a couple is expecting their first child. The obstetrician orders cell-free DNA testing during the early 2nd trimester, which detects a pathogenic type 1 collagen gene variant in the fetus. Scenario C, parents present to the ER with a toddler who's fussy and won't bear weight. X-rays detect a spiral fracture of the tibia, and additional imaging detects evidence of other healed fractures. The parents can't account for how these fractures occurred. Scenario D, a fetus is detected to have bowed limbs and possible fractures on the anatomy scan at 18 weeks gestation. Scenario E, a parent with OI is expecting their first child. No prenatal testing was done, but the baby was born with bilateral femur fractures. Accurate diagnosis of OI allows for accurate genetic counseling, opening the door for families and patients to be referred to our specialty and OI bone health clinics, where they seek access and information regarding prognosis, intervention, prevention, treatment and management, and recurrence risks. In any of these scenarios, genetic testing played or will play an important role in establishing or verifying a suspected clinical diagnosis, providing the essential answer to the question, is it OI, and giving us the initial diagnosis. Ideally, genetic counseling following the initial OI diagnosis should take place over a period of time so that the family and patient can gradually assimilate complex and or potentially distressing information concerning the diagnosis, prognosis, and natural history of OI, as well as recurrence risks of their specific type, while at the same time formulating decisions and strategies for care for themselves and or their child. One must gather and review the information about medical history, findings from the physical exam, review records, test results, and radiographic data, and perhaps especially genetic test results. These clinical data help providers to understand how the patient and family came to be diagnosed with OI. The timing and or age at diagnosis is important. Depending on the scenario that brings them to your clinic, there may be different levels of stress and urgency to their situation. This is a complex and not always linear process for many individuals. The therapeutic relationship is at the heart of my practice as a genetic counselor, but I don't believe you need to be a genetic counselor or trained in counseling techniques per se to navigate this successfully with the families who come to you for care. A little bit of empathy goes a long way. Simply offering congratulations to families who have a new baby, for example, can really help set the tone. The family history is an essential piece of information gathering and is an especially personal aspect of the process. Contracting and listening to a family's story gives not only important health history information, but also gives us as providers insight to how a family communicates and shares health information. Some families discuss everything, others very little. Maybe there's a long family history of OI, or perhaps the patient in the room is the first known person with OI in the family. We have to recognize that in any scenario, information obtained by means of the genetic counseling process can have a family-wide impact. Discussion about the genetics of OI is essential to answering common questions that arise from patients and families about what influence their genetic test result has on the natural history of OI, or can it tell them about the prognosis and what to expect for the individual patient in front of us. Families are interested in how their genetic testing might impact treatment and management options, and they wish to understand, why did this happen? How did it happen? And as thoughts turn to family planning and recurrence risks, what are the chances it could happen again? The information exchange or education process is really a two-way street between the provider and family. I like to start with open-ended questions. What brings you in to see us today? Why are they seeking evaluation in your clinic? Ask what are their questions and medical concerns at this time. You might try some "in my experience" questions. In my experience, people have questions about XYZ. Is that something you've encountered or thought about it at all? You need to be able to address any myths about OI. Key observations include who is at the appointment, what's the interaction between family members and with the patient, what is the climate in the room, who participates in answering questions, and how prepared is the family for the appointment overall. Pay attention to the language of the interactions. Family's use of words, medical terminology or tone, comprehension level. For children, what is their level of understanding and communication? Are they easily engageable? What self-descriptive words or expressions are used, and how do they respond to questions? Regardless of the scenario, there is a lot of information at the beginning. I liken it to feeling like trying to drink from a fire hose. Listening is key on both sides of the exam table. I encourage families and patients to come with their questions written down so they can take notes and come back to the information later for clarification. And in my experience, psychosocial support is at the heart of the counseling process. It really enables the information exchange and educational portion of the process to be successful. So, at the time of initial diagnosis, providers and OI experts can draw a big picture roadmap of sorts for care across the lifespan, both big picture for an OI diagnosis in general and for the specific individual and family in front of you. Who do they need on their health team, and what providers will they have access to in your clinic versus what referrals will you provide to external consultants? Generally speaking, the team needs to include the primary care doctor or pediatrician who's sort of driving the bus on medical care for the family. The genetics team is very important for diagnosis and counseling and can be very involved also in overseeing and helping coordinate care for families. Orthopedics are important, of course, for surgical treatment and fracture management, and endocrinologists for medical treatment of OI, and that's really across the lifespan. Physical therapists and other rehabilitation providers offer lifelong services for people with osteogenesis imperfecta. And likewise, social workers are important for liaising with the school system, child life in the hospital setting, and services for adults as well. GI and nutrition should be available to support questions about growth, and there should be referrals to other specialists as appropriate and needed. Dentistry, hearing, cardiopulmonary, vision, pain management, with an emphasis on health team members depending on what concerns are voiced by the families or that you know about as providers are pertinent to the individual. This includes psychosocial counseling and support. At HSS, where I practice, we're lucky to have many of these providers as members of our core multidisciplinary team, including a social worker, in addition to the genetic counseling services and support I offer with patients who have OI and their families across the lifespan. And last but not least, you want to be able to provide resources. Knowledge is empowering, and families and patients needn't feel isolated when connected with a health team who can support them with resources and connect them with experts to take part in all aspects of care. This shouldn't be an everything everywhere all at once approach, but really offered to families and patients in need at appropriate times. This can be written documentation of a diagnosis and inheritance patterns that can go to other providers or shared within a family. It can be referrals to other providers to manage various systems for the person with OI. You need to be able to assess the support system of the patient and family, and as I've said repeatedly, refer to mental health professionals appropriately, as well as other medical specialists. You can offer peer-to-peer connections with other families locally in your practice and community, and connect with programs in the hospital setting, such as Child Life. The Osteogenesis Imperfecta, perhaps it goes without saying, but is always worth saying. The Medical Advisory Council has created and vetted amazing resources for patients, families, and providers, which are available on the website and available in many different languages. I've pictured the new diagnosis toolkit here, and Tracy Mulray just told us about the adult toolkit, which is hot off the press and coming soon. And please don't forget research. Though it's not everyone's jam, many families appreciate the option to participate in research and feel like they're participating and giving back to the community by helping advance knowledge and treatment for themselves and for others with OI. So in summary, accurate diagnosis of OI allows for accurate genetic counseling regarding prognosis, intervention, prevention, treatment and management, and recurrence risks. Patients and families with OI require not only education, but also psychosocial support to effectively self-manage and have access to services as needed. Genetic counselors work in concert with other health team members to provide a diagnosis, develop a treatment plan, and take an active role with other health professionals to manage the patient's physical, psychological, and social functioning. All in all, this is a foundation built through counseling at the time of the initial OI diagnosis and really maintained across the lifespan with the patients and families we are privileged to work with in our clinics. I want to thank everyone for your attention, and I look forward to questions and discussion if people have any. I'm going to leave this nice artwork up.
Thank you, and great talk. We're happy to take questions now. If you have a question for Erin, you can unmute yourself or just type it into the chat.
Is Dr. Tosi still with us, Erica?
I see.
I am. I was trying to talk on the phone, but can you hear me now?
Yes.
Fantastic. Thank you tremendously, Erin. That was just great.
Hopefully I was so
How-
clear that people just don't have.
What percentage of your families do you get prenatally versus afterwards?
I don't really have a percentage for you, but as a genetic counselor, we see patients prenatally on up through adulthood, at least at my hospital. I'm interactive with a couple of different affiliated academic medical centers in the New York City area. And where we're located in New York and in the Northeast as one of the known centers for people to come for OI care, I do field a lot of calls from my colleagues in the prenatal genetic counseling realm about fetal diagnoses at various stages. The scenarios that I put on the slide are very real, and I imagine other genetics providers here and obstetricians would agree that these are scenarios that come up time and time again. Most of my patients are adults, so.
So I have a sort of question / comment. I find that already so that everything that ever was published on the OI Foundation website, and then the folks go and any pointers or tips I hand out, breakthrough, I really brag about the OI Foundation website, but I would have to be honest and say it's a hard sell with some patients, and it's often those who are not comfortable with their role. They don't really.
I'm afraid you're breaking up so much I can't hear the question. Is it just on my end? I can shut my video off again and see if that helps bandwidth.
No, I think it's Dr. Tosi's connection, unfortunately.
Okay.
I think and hope I'm back. Yes.
There, that's better.
Yeah, I'm sorry, but I'm just curious if you had any pointers on, because this has been an issue that we've discussed a lot in our meetings about how to take better care of patients. And I would argue that it's really a tough go.
Dr. Tosi, do you mean having people access the information like on our website?
Right.
Okay.
Our younger people are certainly more willing and able. They're way ahead of me. But there's a certain group of patients that I can't lead, push, nudge.
How do you nudge them, Erin?
Well, sometimes I sit down with people in an actual clinic visit. We see patients in a multidisciplinary fashion, and I'm not only the genetic counselor, but also the clinic coordinator. So I have a lot of interaction with all the patients when I'm wearing different hats. And one of the things that I do is I help people, like, let's look at this webpage together. Do you think you could click through and do this at home? Do you want me to print this for you here? Is this useful or not so useful for you? And try to facilitate a little bit of a discussion about it. I think it depends on what resources you're talking about specifically. I think the foundation has fantastic resources, and I guess I haven't queried people, but most of the folks that I see have not been uncomfortable accessing them.
Well, certainly the new diagnosis booklet has been incredibly helpful, and it's now available in Spanish, so hats off, that's for sure, to the foundation. We're all very grateful for that. I don't want to close off anybody else who has a question or issue, but if you don't jump in, I have an advertisement.
Hey,
So-
Erin, can I ask you a quick question? This is Jill Flanagan from Atlanta.
Please.
With all the advancements in genetics and us really more focusing on the mutation, I still get a lot of families that are really caught up on. So my type 1 or am I type 4? Am I type 3? Am I type, I mean, the 5s and 8s, those are different. But what would you say to that response? I mean, is it still relevant for us with research? I mean, to me, I say, look, I'm going to treat you for who you are, although I do think our trend in the future is going to really be treating them based on their genetic mutation. So I was curious how you would respond to that if a family asks you.
We talk about this all the time and we address it head on, I guess I would say, in terms of walking patients through what their genetic test report means. That's something that I'm fairly facile at, I feel comfortable saying, and trying to meet patients where they are with respect to what their comprehension level. I draw pictures, I use diagrams, I walk them through the genetic test report. If this was a little bit longer of a time window, I probably would have included that as one of the slides on this session, because I feel like that's valuable for a lot of different provider types. And as you're saying, you're sort of being asked as an orthopedic surgeon, world class, to help dissect genetic test results. We talk about, for our perspective, what different gene variants mean with respect to type, and then also how that translates through to care of the whole person. I think generally speaking, anyone who has a haploinsufficiency variant of the type 1 collagen, the alpha 1 chain of the type 1 collagen genes, those are the folks who have type 1 OI. And any folks who have a variant that actually changes the quality of the type 1 collagen protein, we consider them to have type 4 OI. And I think there are a lot of folks, type 1 is the so-called mildest form, and type 3 is the so-called, severest survivable form. And then OI type 4 is everyone in the middle, and it's a diverse range. And so I think that's a common question. And I have other thoughts that we could discuss in PERTS, and I think it's important, actually, you as the orthopedic surgeons are working with bone as a material in the OR. Type 1 collagen is the rebar in the bone. So depending on what a patient's genetics is, you really need to understand what their genetic diagnosis is and how that impacts the materials you're working with, and also how can we optimize the patients to have good outcomes from surgery, depending on what type or specific genotype they also have. This is near and dear to my heart. This is my favorite thing as a genetic counselor working in an orthopedic hospital.
Awesome.
Great
Thank you.
question. Thanks, Jill. That was terrific. I'm going to work hard to keep us on time, but I'm going to take 1 minute for 2 quick advertisements. Thanks everybody for being here. We're so excited to pull the community of the clinics together. Second, as part of that, everyone I think knows we're trying to do these town hall meetings twice a year. And I want to talk briefly about our upcoming meeting, so to speak, which will be spring of 24. And as many of you know, we have a scientific meeting every year. And we're going to try very hard to get at least one clinician from every clinic to come to the scientific meeting.
I think we just lost Dr. Tosi, but she was talking about the OIF's annual scientific meeting in Chicago every April. And we'd like to make sure that we could bring somebody from each clinic. So please make sure you're keyed into our listserv, and we'll get that information out to everyone. Again, we do have a clinic town hall twice a year, one in person and one virtual. So please stay tuned for information for the spring event. And on that note, I'd like to introduce Dr. Ricky Carroll from the Moores Children's Hospital in Delaware. Dr. Carroll actually was an integral part in helping the OIF with the newborn toolkit that you've heard referenced several times tonight. So thank you. It's really one of our most, if not our most used resource here at the foundation. Dr. Carroll.
Thank you. Thanks for having me. Let me share my screen. All right. All right. So, thank you again for having me. I'm excited to be here to talk about a topic that I'm passionate about, which is caring for infants with OI in like the perinatal period. Um, when I was asked to talk about this, I was asked to talk about OI and other dysplasias. And honestly, I have so much to talk about with just OI alone. I don't think I'm going to get to talk about anything else. But I will say that some of these pearls can definitely be applicable to infants who are severely affected by other dysplasias. And I'm happy to talk about that another time or offline. So feel free to reach out. Here's some of my disclosures. There we go. So I am going to talk about the prenatal period and then delivery and then kind of stage 1 of NICU life, like the first 2 weeks, and then stage 2, which is the rest of the NICU course. And I'm not going to go into tons of detail because of course time is limited, but talk about a couple of like pearls from each stage. And pictures are of our patients, and I have consent from all patients to use these pictures. So prenatal period. So the most common story by far and away that we get from families is, the classic story is that they had a 20-week ultrasound, which showed shortened bowed femurs and multiple fractures throughout the skeleton. They maybe had an amnio that confirmed the diagnosis of OI. Their team kind of runs to the literature, finds a case study from, say 1993 that reports a fetus with the same collagen 1A1 mutation who died within hours of birth. And so their team comes back to them and recommends termination or comfort care. And then that family goes to social media looking for if there are any other options and somehow makes their way to and reaches out to us. And so what do? We do some of the same stuff, just with a bunch of caveats to it. So yeah, we look up the, genetic change and see if there's anything in the literature, but there are caveats to it that I'll get to. And we obtain and review the images, but again, caveats there. And we meet with the family and we talk about the uncertainty. We talk about possible prognostic outcomes, and we talk about different delivery room scenarios, and then we kind of go through what the family is hoping for, their what's most valuable to them, and make a plan that's in line with their goals of care. So what are those caveats that I'm referring to? So in the prenatal period, like first and foremost, there is like an immense amount of uncertainty, right? So it is, as many of us know, exceedingly difficult to prognosticate survival probability prenatally. And truly, there is no definitive way to determine the severity of OI in utero. Most importantly, the presence of fractures alone, or even the number of fractures, is not a determinant and does not indicate lethality. For many of us, that might be obvious, but so many times we hear from families that they like this baby in this slide, family met with a couple of different local NICU teams who all said because of the look of the femurs and the look of the ribs that their infant had lethal OI. And you can see from the picture that this baby clearly does not have lethal OI because she's alive and not even on intubated, with just some ram nasal cannula. So it's just, something that I'm always surprised by, the fact that there's a lot of institutions and teams out there, or, MFMs and OBs and people working out there who are under the assumption that if you see fractures in utero, then it indicates lethality. And that's of course not the case. It is really hard to prognosticate, but we're always trying to do our best to make an educated guess. And, you know, one of the things that's most important that I've kind of learned over time is that the most important thing for figuring out if a baby can survive is, do they have enough lung tissue to support their body, right? Like, were their lungs given the opportunity to form and grow in utero? Because if there are so many rib fractures and the chest wall is so narrow and so small, then the lungs won't have the opportunity to grow to an adequate size to support the body. And so when we're looking at ultrasounds, we're looking at the chest wall and we're looking at the chest circumference and we're looking at the ribs and how much lung tissue is there. And we're trying to make a, you know, prognosticated guess as to if this infant is going to be able to make it through. And one of the things that we use is a thoracic to abdominal ratio. Now, it is certainly not a perfect thing, but you know, in general, the typical ratio is 0.9 to 1. And we know that we get worried that there might not be enough lung tissue there if that ratio is below 0.6. What I will say is that we've seen lots of ultrasound reads that have a ratio of, you know, 0.7, 0.8. And because of that ratio, it says this is consistent with lethal OI. And we have also cared for many infants who have both delivered or been transferred to our NICU whose ultrasound had that read and is currently alive. So we know that that area from 0.9 to 0.6 is a really viable area, and one that there's, you know, that we feel hesitantly optimistic when we see that ratio in our report, as opposed to what the report actually says. And then the other thing that, of course, you know, many of us know is that genotype does not equal phenotype. Just how we see, you know, you see siblings in clinic and they have the same genetic change, but their OI looks really different. The same is true for infants. So, you know, just because there's a case report of an infant with the same change from 1993 who didn't survive, we know that one does not equal the other for a lot of reasons. One of them being that we have a bunch of other genes that are at play. Another one being that it's dependent on the gestational age of the infant. We know prematurity really affects the ability for bones to mineralize, ribs to mineralize, chest wall, lung development, etc. And also because we have significant advancements in medical technology that allow for children who were previously not able to survive today. And in addition, it's kind of a self-fulfilling prophecy, right? So if an infant who was diagnosed with lethal OI wasn't given any respiratory support or pain management at the time of birth and then didn't survive, does that mean that an infant that gave those things wouldn't be able to survive? Of course not. We don't know that. So it's hard to use a case report from 20, 30, 40 years ago to prognosticate for an infant today. So moving into the delivery phase of things, you know, of course, there are a number of beautiful research studies kind of looking at the mode of delivery. And, you know, essentially what has come out of them is that C-section and vaginal delivery are fracture neutral, that one is not beneficial, you know, decreases the number of fractures over the other. And the way that we certainly offer cesarean section to the moms who come to our advanced delivery program. And I think the most important thing that we do is that it's what the OB on our team does a beautiful job of doing is, you know, making it a joint decision that we talk through the risks and benefits of each mode. And it's also an individualized decision. So instead of it being that all of our babies get a C-section or all of our babies get vaginal, it really has to do with the infant that we're seeing in front of us. So, you know, what is, of course, the positioning, you know, what is mineralization of the skull look like? What is the size of the infant, and other maternal things that are coming into play as well. But it's joint decision making, recognizing that the number of fractures isn't, necessarily going to change based on delivery alone. And when we're preparing for delivery, we have somewhat of an equipment checklist. Specifically, one of the things that we always use is an egg crate mattress draped in blankets and blue chucks. And the reason for this is not only because it gives a kind of soft surface for the infant, of course, but it also allows us to move the baby and block from one location to another. So instead of having to move the baby, we move the egg crate from one place to the other so that we don't have to disrupt the baby and move them and cause any other fractures or pain. And then we have additional blankets to aid with positioning for anticipated intubation. And we have a fiber optic laryngoscope for intubation as well. We have OB and neonatal huddles to review team roles and review a clear plan for retrieval and positioning. And then our resuscitation plan, we do follow NRP, but just with some caveats, with some minor, adjustments for the infant in front of us. So do we dry and stim? Yes, but gently, of course. And if a baby needs PPV, do we do it? Yeah, we do, but we try not to hyperextend the neck if we don't have to. We do offer chest compressions for families who are, for whom that is in concert with the goals that they're hoping for. But we might think about using epinephrine before going to chest compressions in an effort to not do chest compressions if we don't need to. And if we do need IV access, which for almost all of our babies, I think all of our babies we have inserted a UVC and tried to avoid a peripheral IV if possible. And then, of course, when we're transferring a baby to our NICU, we use the egg crate to do so. All right, so moving to NICU care. We think about NICU care, and I kind of attribute these stages to Dr. Mike Bober, who really clarified this for our team, which is that there are really 2 stages to infant care in the NICU. Stage 1 is that 1 to 2 week time period when we're allowing fractures to heal. So we're waiting for callus formation and we're waiting for clinical evidence of healing. And in that time frame, we're doing certain things to allow for fractures to heal and supporting the baby. And the reason for this is because we know that birth is super traumatic, right? We know that, and for a baby with severe OI, it's going to be even more traumatic. We expect a high fracture burden, both from prior to delivery and during delivery. And so the name of the game is airway, breathing, circulation, your ABCs, and pain management. And so it's really, giving respiratory support, pain management, supporting the infant while we let those fractures heal. So what is the name of the game in stage 1? Or this first step is meeting your patient. It's really just observing the infant and seeing what's going on. So watching chest wall movement, watching vital signs, looking for extremity movement. Is the baby moving their extremities or not? These are indications of how significant the fracture burden is and how significantly the infant is affected. And what are your immediate needs in that first couple hours? Well, getting a weight. So hopefully you've weighed your egg crate ahead of time, and then you can move the baby on the egg crate to get your weight. Getting a UAC and a UVC so you have access, a chest x-ray to evaluate the lungs and evaluate the ribs, and then offering as much respiratory support as needed for the infant to get through this stage. So in terms of respiratory support, the name of the game is PEEP. So, we know that there is a lot of chest wall compliance. There's going to be rib fractures. There might be some splinting and guarding. And what the infant will really need is some positive pressure to stent open those airways. PEEP can be on, at as high as 10, 12, or even higher, as much as they need for adequate expansion, gas exchange, and comfortable breathing. And then the other main part of this time is pain management. Many of these infants will require a continuous morphine infusion, which we titrate to effect, and then given as excuse me, and then as needed dosing of morphine or a different opioid as well. And it's really important because it can help decrease the degree of splinting and guarding, improve synchrony, and facilitate comfortable breathing. And then the other thing we do for pain management and to encourage, bone healing is that we cluster cares. So we try to limit hand-on cares as much as we can. Instead of doing a wait here and vital signs there, and then giving this med and accessing then, we try to do it all at once. So all at once, everyone goes in, you get a wait, you do with whatever respiratory needs are needed, you do vital signs, you do everything at once, and then try to, not touch the baby again for 6 to 8 hours until care is needed again. Many of our infants will require nutritional support as well, either through TPN, or either, through TPN or through enteral nutrition through an NG tube. And the thing that we kind of harp on for our, with our neonatal team is that, many babies in the NICU, weight is a big thing in the NICU. And for the similar aged peers, those infants in the NICU, the weight gain goal is typically 20 to 30 grams a day. And one of the things that we talk about all the time and are always, harping on and reminding our neonatal team is that our infants, their weight gain goals are going to be substantially lower than your, average stature infants in the NICU. And that's because they have a smaller skeleton, and we just expect that their weight gain is going to be slower as well. And so their weight gain goals are typically for our severely affected infants, 5 to 10 grams per day. And then we're making sure that they're getting all their micronutrients, ensure that they're getting their vitamin D supplementation. We talk about minimizing diuretics, or at least those calcium spilling diuretics as best we can. Of course, if Lasix are needed, but we try to minimize them when we can. And we also encourage our infants being on a bowel regimen to, keep the bowels moving to decrease the chance of abdominal competition, because we know that there's just such a small space. And if there's abdominal competition, it could affect respiratory, status. And so keeping stools soft so that the belly is nice and soft can help the respiratory status overall. And during this time, the other thing that we're doing is ensuring that we have the right diagnosis. So, even though OI can be made clinically, it doesn't necessarily have to be made genetically. We need to make sure that we feel like we have the right diagnosis and that we're, going down the right path. Most importantly, that we're ruling out hypophosphatasia, because as we know, we don't use bisphosphonates in hypophosphatation. And before we jump to using one, we want to make sure that we have the correct diagnosis. And so that kind of leads me to the use of bisphosphonates. We really try to give the first cycle of, and we at our institution, we use pamidronate, and we really tried to give the first cycle of pamidronate as early as possible if clinically possible. So, ideally we get the first cycle of pamidronate in towards the end of this first stage. Ideally day 8, 9, 10 of life, right before we remove that UVC. And so that we don't need to get a new peripheral IV just to give the PAM. But most importantly, an infant has to be stable from both a respiratory and feeding perspective before we would give that first cycle. And so sometimes it's just not possible if an infant's, having a lot of trouble with that transition. But our goal is to give it as soon as we can. We typically start with our first cycle is a reduced dose. So that first day will be a quarter of the dose, and then days 2 and 3 will be half of the dose. And in general, our infants really tolerate this just fine. The most common thing that we see is hypocalcemia. So we follow those ionized calciums really closely and give calcium supplementation as needed. But we don't typically see like that flu-like reaction or respiratory distress or anything like that. That being said, we are really cognizant to wait until an infant is stable from a respiratory and feeding perspective before we give it. And then we plan to give that first full cycle about 4 weeks later, although sometimes it gets pushed out depending on how the infant is doing. And from there, we use your typical 9 mg per kg per year dosing given every 8 weeks. Excuse me. We really encourage parental bonding. We want parents to hold their baby as soon as possible, but we also want those fractures to heal and to have good pain management in those first 2 weeks of life. So in general, what we do is we have the infant remain on an egg crate or the pillow that they're on, and have the family hold on the egg crate so as to limit movement, decrease pain, and promote healing. And we might have PT and OT involved with positioning as well. But we do very much encourage parents to hold even, as early as day 1, 2, 3. And then once we've gotten through the first 1 to 2 weeks and we start to see evidence of fracture healing, so we see that the vital signs are normalizing, we see that the baby's needing less pain medications, we see that the baby's moving his or her extremities more, then we know we're moving into stage 2, which is really weaning the supports as best as we can and working on educating the parents to get them comfortable with hands-on care for home. And these are just a couple of pearls for this, next stage in care. First thing to know is that long-term daily opioids are not typically required, and our goal is to get infants off of all opioids significantly prior to going home. So after that first 1 to 2 weeks, we're definitely weaning down on pain medications. And get off of those opioids and then kind of transition to using Tylenol as needed for any discomfort with, of course, as needed opioids for new fractures or new pain or new events of any sort. One of the things that we are always, reminding our teams is that we certainly don't get x-rays for every new suspected fracture. We're just watching the infant. So if there are decreased movements of an extremity, any signs of pain or discomfort, changes in vital signs, we just assume that there's a fracture present and treat as such. So Tylenol as needed, increased respiratory support as needed. We might offer a soft splint. We certainly have our orthopedic team, Dr. Franzone, and the team come and meet the child, meet the family, go over splinting care prior to discharge. And if there is concern for new fractures, we'll have her or the team come by and evaluate, maybe put a soft splint, talk to the family, and we'll use Tylenol or as needed morphine to kind of get the infant through. And then long-term respiratory support. So we know that there's excessive chest wall compliance can lead to respiratory insufficiency. They could have pain-related splinting. There could be rib fractures. This can all lead to chest wall movement and shallow breathing, which can lead to a need for high PEEP for good gas exchange. Some of these infants, we can wean that in the coming weeks as the baby heals. But for many of our infants who are severely affected by their OI, they will need some kind of respiratory support, in that first year of life. Majority of our infants will go home on CPAP via RAM nasal cannula. So a nasal cannula in the nose that's a little bit larger than your typical nasal cannula connected to a CPAP machine, delivering a little bit of positive pressure. And if an infant goes home on that, we typically counsel that the goal is to be able to wean that off by about a year of life. Now, we have certainly had infants that just fly through and are off on, by 6 to 9 months. And then we have other infants who kind of teeter along and need it for more like 18 to 24 months. But in general, the goal is to have them off by around a year. And then we have also had some infants who have continued to require mechanical ventilation and have gone on to have a tracheostomy placed. A lot of times that is in the setting of an infant who also had complications related to prematurity, or just prematurity plus OI, leading to respiratory insufficiency and chest wall compliance. And if that does happen to be the case for an infant, we typically counsel that the goal is decannulation by school age. But in general, we don't expect this to be a tracheostomy for life, but a tracheostomy to help them through, the first couple of years of life.
Ricky?
Yes.
I apologize. I need to stop you there, just because we're now running a bit over. Oh, good. We're right at the end anyway.
Yep.
Great. Okay, that was terrific. And but I'm going to push us to our last talk. But I hope people will stay on after because I'm sure you have lots of questions. That was spectacular. And I love your egg crate concept. So we're going to finish up. So I started to say earlier, and I kept getting disconnected, is we really appreciate the feedback and evaluation that everyone sends us on these conferences. And tonight's talks are really all based on that feedback. So please be sure to tell us the good, the bad, and the what to do next when you get the evaluation form. But last but certainly not least, one of the great challenges of my clinic is making sure the kids get to school and stay in school. And so I am thrilled to be supported by social work, and particularly it gives me great pleasure to introduce Nancy Harry and Sarah Greenbaum, who are going to talk to you about maximizing school accommodation and education plans. Thank you for being here.
Great. Thank you for having us. I am getting us pulled up right now. All right. So, hi everyone, my name is Sarah, and myself and my colleague Nancy Harry, we are going to be presenting on how we can support our OI patients in school. So just to go over what our presentation will look like, we'll try to keep it brief. First, we're going to touch on the history of school accommodations and what that looks like, including what an individualized education plan or an IEP looks like versus a 504 plan. And then Nancy's going to talk more about how we can support OI patients in school, and also talk through OI school note templates that she has put together for medical providers to use. So first, disabilities in schools started getting recognized during the Rehabilitation Act of 1973, and that is where a disability was defined as a person who has a physical or mental impairment that substantially limits one or more major life activities, a person who has a history or record of such an impairment, or a person who is perceived by others as having such an impairment. And within the Rehabilitation Act, Section 504 said that all people with disabilities must receive appropriate accommodations in any program that's federally funded. And so that federal funding also extends out to our public school system. Following this, in 1975, about 2 years later, there was a revision that was made, which said that all students attending public schools or federally funded schools have the right to a free and appropriate public education, which is known as FAPE, in the least restrictive environment. So giving them an environment where they are able to access the same level of curriculum and extracurriculars compared to their peers to the best of their ability. And then finally, the Individuals with Disabilities Education Improvement Act of 2004 came along, or it's called IDEA. And that was saying that if a student has a diagnosed specific disability, they must have a corresponding education plan that includes special education services. And so there are 13 specific disabilities that qualify for a special education plan, including orthopedic impairments. So that might be cerebral palsy or OI. A specific learning disability, which can include dyslexia, written expression disorders, dysgraphia, other health impairment, which might include ADHD, autism spectrum disorder, emotional disturbance such as bipolar, OCD, schizophrenia, or oppositional defiance disorder, speech or language impairment, visual impairment, deafness, hearing impairment, deaf blindness, intellectual disability, TBI, or having multiple disabilities. So when we're looking at 504 and IEP plans, oftentimes these terms get used interchangeably, but they are different. So a 504 comes from the Rehabilitation Act of 1973, which is saying that modifications must be made when a student is excluded from a school activity due to a disability. So a student's physical or mental ability may impact the extent to which a student can participate in school instruction. It does not change the curriculum that a student learns, but rather extends out services for the student to participate to the best of their ability. And so a couple examples are a child's asthma requiring intermittent breaks when participating in physical education class, or a child who requires extended time to complete tests or exams. What happens with a 504 plan is typically a parent initiates contact with the school, and it's a meeting that occurs between school administration and parents, as well as, if any of those classes or services are impacted, looping in those teachers. Then we have individual education plans, or IEPs. And so that is when specialized education with supports that can be accessed are within a student's curriculum. They must have a diagnosed disability as listed through IDEA. And so this is modifications to the curriculum, which means that the curriculum can be changed. So IEPs have to include measurable goals that are divided into academic and social emotional categories. This also includes how progress will be measured and what supports are there to help that progress occur. There are other support services that are often involved, which could include speech therapy, occupational therapy, physical therapy, or school psychology involvement. And so an example would be within 6 months, the student will be able to bring their hands over their head simultaneously with 90% accuracy and 4 out of 5 attempts. And then one that's focusing more on the social emotional is that a student will demonstrate emotional regulation skills given 3 verbal de-escalation prompts 2 out of 3 times. All right, now I'm going to turn it over to Nancy to talk more about what it looks like specifically for OI patients.
So this thinks I'm in driving mode and it won't let me have video and sound at the same time. Can you all hear me?
Yes.
Yep.
Yes, we can hear you.
Okay, so Sarah, you'll have to do the slides because I can't see anything now. But so in the few minutes we have left, I'm just going to talk about, I work with Dr. Tosi. I'm the outpatient social worker, and we get called upon to do a lot of school coordination, especially when the kids are starting school. A lot of these kids have not gone to school or preschool or daycare or anything like that prior to starting kindergarten for different reasons that include the child's had too many medical issues to consistently be out of the home, or the parents haven't been able to work, so they've been home with the child anyway, or they can't find a daycare, very common we hear, which will accept the child, or where they feel comfortable sending the child, where they think the child will be safe. Or they may have attended daycare or pre-K, but it's still a big transition into the larger school setting and classroom setting with, more kids, a bigger building, less direct supervision. I think go on to the next slide. So when the child enters kindergarten, we find some combination of parents who are understandably very afraid to send the child to school, or parents who want to normalize the child's experience and don't want to hold them back, so don't want too many restrictions. We get school staff who are terrified they will accidentally injure this child, or we get school staff who don't know anything about OI and totally minimize and think the parents are just overly protective. We get a lot of worries about liability. And also it can be expensive for the schools to do testing, to have IEPs, develop 504 plans, implement accommodations. A lot of schools just resist doing it. And we're in the DC area, so we're dealing with Maryland, DC, and Virginia, with all these counties and all these different school systems. It's a huge population. So on to the next slide. So we are often asked by parents or schools to write a letter documenting the child's medical history, the restrictions and accommodations, especially with playground and PE. And we have these sort of draft templates that are generic, one for milder OI and one for more severe OI. And we attach those to this presentation. So if anybody wants those, you feel free to take them and make them your own and do whatever you want. So we've attached those, and just to briefly summarize what those are and what we do with them. We have this informal template. First, I go to Dr. Tosi and individualize that template to the child, and then we write a draft. We send it to the families to get their input. When everybody's happy with it, we put it in the form of a letter, give it to the parents. And ideally, then the school staff, does something with that. And sometimes they start and they call us along the way, and we adjust things as we go. So on to the next slide. This is a very, very fluid process with a lot of different individual variables, of course. But generally, we have a brief description of OI, a little bit about that fractures can occur even with very routine activities, that they need reasonable accommodations. That's an important keyword to put in. We call for, suggest that they might need a PT and OT assessment to determine the accommodations, because sometimes you have to say you want that before the schools will do it. We say that if a child has an injury or surgery, we'll have a different set of restrictions. So we're not trying to cover, every possible scenario in these letters. And we mentioned that they might need a one-on-one school aid in more severe cases, because that's something the schools really, it costs them a lot of money, and a lot of them really try to avoid it. So next slide. And then just these general school needs, which are all in that letter. You can see them here, front of the line, walk, don't run, hold the stair railings, let them self-limit. They might need more supervision. The big questions that come up are about PE and recess. So Dr. Tosi always wants no contact sports. For the milder kids, they can run, skip, hop, jump, encourage walking. They may need adaptive PE, that we're willing to review checklists that may come up. Sometimes the schools have their own checklists. And then recess and playground, we're always saying no monkey bars, usually no jungle gyms, no hanging by the arms. Depending on the kids, sometimes she allows swings and slides. And if the child's in a wheelchair or using a walker or other adaptive equipment, we always want to know what the schools are going to do. They're not going to just make the kids sit, out there at recess with nothing. Sometimes they've got adult monitors who can be with them out on the playgrounds. So a lot of different versions of that. And we have parents who get very creative, who volunteer to help design the playground equipment. Sometimes the schools have 2 sets of playground equipment, and the one for the younger kids is okay because everything's smaller. We have families that videotape or photograph the equipment and then show it to us so they can decide if that's okay. Anything basically to try to be more inclusive. And then finally, the last thing we say is we have a paragraph at the end of the letter saying if there's an emergency, treat everything as a possible fracture. If the kid's complaining of pain or guarding or not themselves, or they fell down and they say it hurts, treat it as a possible fracture. The schools have emergency protocols anyway. They don't usually need any different kind of a protocol. Notify the first responders that they're followed at our hospital, because in our area they can get taken to the closest ER where they have no knowledge of what to do. And we hope sometimes they'll eventually get them to Children's where we know them. So that is basically it. I know we covered a lot of ground, but I mainly wanted to just tell you that those letters are out there and you're welcome to use those. And what I was covering was just summarizing kind of what was in those letters.
And right now I have just the OI mile type. We'll make sure to send these out to everyone so that everyone has access. As Nancy said, but here, we just have where it's saying the name, date of birth, blanks are where the patient's names goes. And, as we went over pretty quickly, here's each piece broken down into what needs to be included.
All right.
Yeah. Anyone have any questions?
That was great. Thank you very much, guys. I do think it is a battle to keep these kids in school and exercising. And we've had a lot of programs over the years about PT, but for at least in our area, any kind of reasonable school PT ends at a quite early age. And they're only willing to provide PT that will prove the academic achievements of the child. So making sure that they are exercising when others are having PE is really important. And I hate for my kids to be on the sidelines, that's for sure. So thank you very much for that presentation. So we are actually 5 minutes early. So
Oh no.
Oh no, we lost
So
her.
close.
So close. Yeah. Well, Eric and I will continue her thought, but we thank everyone for joining us tonight. We will have all of this information out to you, including those letters. Sarah, if we can share those with people, that would be terrific. Erica, do you want to close us out here?
Thank you again for taking the time tonight. You'll receive an email right after this call with all of the resources we've talked about, the toolkit. In a later email, we'll send the documents from Sarah. And please stay tuned for the date for the next call.
Yeah, thank you to all of our speakers tonight too.
Yes, great talks tonight. Thank you. This program was recorded this evening. So once that recording's ready in the next 2 weeks, we'll also email a link back to you so you can share it with your colleagues. Thank you. Have a great night.
Thanks, everyone.
Bye, everyone.